They're all different ages, about the gift of our body and of our reproductive self. So first, Dr. Nancy Hernandez Heyne is a physician at MGH and a faculty member at Harvard Medical School. She received her medical degree from NYU and completed a residency at Brown with us. She's board certified in both internal medicine and pediatrics. She has completed training in various fertility awareness-based methods and a fertility education and medical management FEM. She lives in Boston with her husband, Tommy Heyne, who you just heard from, and their 3 children. I have a conflict of interest. I'm the chairman of the board of FEM, Fertility Education and Medical Management, just so you all know. And then you're going to be hearing from Christina. Christina Valenzuela is married to Andy, who was in the class of 2004 here at Portsmouth Abbey. And her in-laws have been tremendous supporters of Portsmouth Abbey. And that's Javier Valenzuela and Mary Beth Klee for many, many, really decades. Christina is the owner and founder of Pearl and Thistle, where she offers a unique blend of theology and science to bring better, lifelong body literacy to Catholics. She's the author of The Language of Your Body, Embracing God's Design for Your Cycle. And I ordered it last night on Amazon, and it's coming on Monday, so you can get it, no trouble. Christina is certified in the Boston Cross-Check method of natural family planning since 2013 and has provided menstrual cycle, fertility, and NFP programming for diocese schools, health centers, and parishes around the country. Her undergraduate degree is in philosophy and theology from the University of Notre Dame, and she has a master's in theological studies from Harvard Divinity School. Christina lives with her husband, I call him Andy, here's Andres, and their 4 children outside Boston, and is a life-professed member of the lay fraternities of St. Dominic. We're going to start with Dr. Heyne.
I will be speaking to you all about a Catholic physician's response to women's hormonal health. I will, in this talk, review the current secular model for women's hormonal health, discuss some of the advantages of what's called restorative reproductive medicine, or RRM, which is a holistic model for women's hormonal health. And we'll also discuss educational initiatives that support this holistic approach. So the current state of women's health is very tied in with contraception and abortion. Unfortunately, they've become synonymous with women's health these days. How did this begin? A little bit of history. So in 1921, Margaret Sanger founded the American Birth Control League, and this is the antecedent to Planned Parenthood, which pushed for contraception and eugenics. Margaret Sanger herself was a very vocal eugenicist. So after decades of this sort of activism, Inovid, the first oral contraceptive pill, was approved in 1957, and this was for the treatment of gynecologic and menstrual disorders. Just 3 years later, Inovid was approved with the purpose of a contraceptive, and in the 1960s, there was pretty heavy marketing trying to promote the OCP to men and women. And by 1965, millions had been made in sales, and a total of 6.5 million women in just a few years were on OCPs. And today, OCPs are prescribed. It's almost a blanket solution, for a lot of menstrual disorders, which I'll cover briefly. So some gynecologic disorders that are managed by hormonal contraceptives include the ones I listed here, everything from polycystic ovarian syndrome, endometriosis, acne, painful periods, heavy periods. There's a lot of talk about menstruation. I never thought that I'd be speaking about this in a Benedictine Abbey, but here we are. So these are some gynecologic disorders that are managed by, again, hormonal contraceptives, aside from the purpose of contraceptive use. Not surprisingly, secular medical societies like ACOG, the American College of Obstetrics and Gynecology, strongly support the use of hormonal contraceptives for these medical conditions. The issue lies is that hormonal contraception acts as a pharmaceutical band-aid for these conditions. So they're pretty effective in masking the symptoms of these conditions, but they're not very effective in addressing the root cause. The way they act is that they're synthetic hormones that prevent women from having menstrual cycles. In general, they prevent ovulation, and without ovulation, there's no menstrual cycle. And without a menstrual cycle, there are no symptoms related to the menstrual disorder. That's how they work. OCPs and intrauterine devices, or IUDs, are considered pretty convenient. They're pretty quick to prescribe. They're relatively cheap, and quite frankly, they're an easier option as opposed to really delving into the history of what's going on, doing the diagnostics necessary, and offering the therapy that's needed. So, unfortunately, gynecologic disorders remain underdiagnosed, undertreated, under-researched. For example, it takes about 8 to 12 years for a woman to receive a diagnosis of endometriosis. And this is in large part because, let's say a woman presents with the hallmark symptoms of endometriosis, one being painful periods, and almost immediately the physician will recommend an OCP. And so it's not until years later, when perhaps the woman is struggling with infertility or other sequelae of the endometriosis, that the diagnosis is finally made. There are also risks involved with hormonal contraception that includes breast, cervical, liver cancers. It's a WHO class 1 carcinogen. This is the highest classification of carcinogens. It is associated with blood clots, heart attacks, stroke, high blood pressure, and it's also associated with unwanted pregnancy in 8% of cases with typical use of OCPs. And yet, despite these risk factors, these side effects rather, OCPs are seen as the only viable treatment for gynecologic disorders. And within the medical community, some would say, well, this is the lesser of two evils. The pregnancy risks are greater than the risks of hormonal contraception. You will hear that a lot amongst the medical community. And these are real risks. I will relay an anecdote. When I was at a CMA, or Catholic Medical Association conference, one of the speakers was speaking on hormonal contraception, and he posed the question to the group, how many here have seen any complications of OCP use? And every single hand in the audience went up. So it's a known issue. I myself saw a woman in her 30s pass away from a pulmonary embolus with otherwise healthy, had been on an OCP, and she unfortunately passed away during our care in the ICU. So this was during my residency training. So it definitely is a real thing. And, you know, because the reality is, too, that women's fertility is overall viewed as a disease. There's even a billing code for this that I included here of unwanted fertility if pregnancy is not desired. And then, of course, if pregnancy is desired, then there's the option of IVF, which brings on, you know, that could be a whole nother talk, a whole nother conference on the ethics and morality surrounding IVF, but that's also an area of concern. I've also have rotated through IVF clinics during my medical training, and it's very eye-opening what's happening and how embryos are being created, and they're really treated as inventory, and they're chosen based on their quality and certain characteristics that are looked for by the parents, by the IVF doctor. There's the need, quote unquote, the need for selective reduction, which is aborting 1 or 2 babies if there's multiple, if it's a multiple pregnancy with twins or triplets. And this was something else that I also witnessed in the clinic, where a woman was being pressured by the IVF doctor to abort one of the babies, and in a very callous way told her that they would choose the weakest or the smallest baby of the 3. When she asked how it would be done, how would they choose, and that's how they choose. So, you know, this is the state of women's healthcare at this time when it comes to reproductive health, when it comes to our fertility, and so that's where we are right now. Ironically, though, academic physicians, they do acknowledge the importance of menstrual cycles. Interestingly, in 2015, ACOG recommended that the menstrual cycle be treated as the 5th vital sign for women, and yet, contradictory to that, they're recommending suppressing menstrual cycles. Interesting. But I will agree that women of reproductive age, it is needed to have, for a woman of reproductive age, to have healthy menstrual cycles for the health and development of nearly every major organ system of the body. Because a healthy menstrual cycle is suggestive of hormonal balance for a woman. And yet, our current medical approach seems to ignore this fact. So what is the alternative to this traditional model, if you will? So this is the restorative reproductive medicine, or RRM, is a holistic model for women's hormonal health. It's an authentic, more comprehensive approach to women's health. It identifies and treats root causes of reproductive and hormonal dysfunction and aims to restore the reproductive system. The woman's cycle, and likewise her fertility, is not considered a disease to be cured or eliminated, and instead they're actually diagnostics. There's therapeutics that acknowledge the importance of a woman's cycle. The menstrual cycle is indeed considered the 5th vital sign in RRM. It's considered a biomarker that gives information about the overall health of the woman. And the foundation of this is cycle charting, which is a detailed account of the woman's menstrual cycle. And a woman can cycle chart with one of many different methods here. These are fertility awareness-based methods. It's not the rhythm method, which some will think it is. These are evidence-based, fertility awareness-based methods listed here, and a woman can track several or any of these different biomarkers, everything from bleeding patterns, cervical mucus patterns, hormone levels with at-home kits, and basal body temperature measurement. So there are many options depending on what a woman chooses to do and chart her cycle. So this is just an example of what a chart can look like here. And this really provides a lot of information for RRM physicians because they can look at the cycle and say, well, this perhaps looks like too long or too short of a cycle here. Oh, there may be bleeding in between cycles. Are the biomarkers indicative of ovulation or a lack of ovulation? And all of this provides information about the overall hormonal state of the woman. And there are even now smartphone apps that help in tracking all of this. The RRM protocols, which I'll outline some here, they diagnose and treat gynecologic issues, including infertility, using, again, this charting data and growing body of research. The first to really develop these protocols is Dr. Thomas Hilgers in the 1970s. He started what's called natural procreative technology, or NAPRO technology. And this includes both the medical management of some of these fertility issues and also includes surgical management. So physicians who are trained under this area of NAPRO technology, they also develop the surgical skills. Not some physicians do. It's not required, but there is the option of developing the surgical skills to manage some of the issues that I outlined before, in particular endometriosis and PCOS. They have the training for that. There's also FEM, which Dr. Deaconton mentioned, or also called fertility education and medical management. So their focus is mainly on medically managing these women health issues. And this was founded actually just pretty recently, back in 2012, by Anna Halpin, along with Dr. Pilar Vigil, who's a Chilean reproductive endocrinologist, and they work together with the Reproductive Health Research Institute. And they work together to develop these, again, with really robust research, evidence-based protocols on how to medically manage these medical issues. And what's unique about them compared to NAPRO technology is that they address women's health issues across the lifespan. It's not just during reproductive age with just the purpose of of natural procreation, but actually to restore women's health even during the perimenopause, menopausal years. And then there's neofertility, which is even newer. It's essentially a branch off of nanotechnology. They're mostly based in Ireland, but there are these worldwide efforts to really advance women's health from where it is right now. And these protocols involve diagnostics, therapeutics that I mentioned, so anything from enhancing a woman's fertility to just balancing hormones for good women's health. And this treatment is collaborative, including nutritionists, surgeons. I did want to share there are many protocols, obviously I can't go through everything now, but just one very commonly used one is that of progesterone support in pregnancy. So unfortunately, in our current secular medical model, it takes a woman having 3 miscarriages for her to be adequately worked up and to investigate if there's an underlying issue. The thought being that before those 3 miscarriages, it was all just, it could have been a random chance and nothing could have been done about it. But once they hit that 3 mark, this light bulb goes off and it's like, okay, there could be something going on here. So, so nanotechnology does not have that philosophy. They think that 1 miscarriage is 1 too many, and that there could be some underlying issue there. And so they acknowledge that a very common cause of early miscarriage in particular is low progesterone. And so they're proponents of monitoring progesterone, particularly women who have had a history of miscarriage. And so based on studies that they have done, they've obtained optimal levels of what the progesterone levels should be. And so with this monitoring, they can assess whether or not a woman needs progesterone supplementation and support a woman and in her pregnancy in that way. And there have been many success stories related to this. So RRM really is a hidden gem for women's health, as strong evidence, but not many medical providers or lay people know about it. Many OBGYNs still think that fertility awareness-based methods are the old rhythm method. And here I have a clip from our own electronic medical records where, other than your typical contraceptive options, they list the rhythm method, and fertility awareness-based methods are not even listed as an option. So this sort of antiquated thought there. So what can we do to raise awareness? So both, clinicians and women, there's not a lot of awareness about RRM, and so education is really critical at this point. And so I just wanted to highlight 3 initiatives, including Pearl and Thistle, which Christina will speak further on, but that these are initiatives that are moving the RRM forward. So one is FACTS, and so FACTS, it stands for Fertility Appreciation Collaborative to Teach the Science. And FACTS is aimed more so at healthcare professionals and trainees to teach future, whether it's medical students, residents, or even active providers, to teach them about fertility awareness-based methods. They even offer electives for students and residents. And their goal really is to change the culture of medicine, change the culture of women's health, to teach that fertility is not a disease, that good medicine means a more holistic, hormonally informed approach. And because the reality is there is such a high demand for these services and there are not enough providers. For someone who lives in Massachusetts or Rhode Island, for a woman seeking RRM care, the only NACRO-trained surgeon is in New Hampshire. So they have to travel an hour or 2 hours to seek this sort of holistic care, someone that's really going to treat the underlying issues. So there's definitely a high need, and so we need more providers that can provide this need. And then the other layer of raising awareness is within our own communities. And so there's Pearl and Thistle, Christina, who we have the honor of having here. She started Pearl and Thistle to promote body literacy even before menstruation begins. So this is really important. I would say that a woman presenting when she's already struggling with infertility, I would say that at that point, it's too late. We should capture any hormonal issues or any concerns sooner, and a young lady being able to be body literate and to know how to observe cyclical changes in her body, to teach that early on, it's a lifelong, journey there, and it's important to know, is it, what's normal, what's abnormal, what do I need to present to perhaps her physician. And so we'll hear more about Pearl and Thistle from Christina. But there's another group, there's also Teen Star, who does something very similar, more so geared towards teens, but again, with the whole idea of promoting body literacy, encouraging cycle charting, and interestingly, they've actually done studies that the Teen Star program in particular has actually been pretty effective in promoting abstinence amongst the teens who take the courses. So all very positive things here. And I just wanted to close with this lovely quote by St. JP2. Therefore, the church gives thanks for each and every woman, for perfect women and for weak women, for all women as they have come forth from the heart of God in all the beauty and richness of their femininity, as they have been embraced by his eternal love. So this is what, hopefully grasp some of the importance of really having an authentic women's health care that really seeks to heal while acknowledging and respecting the uniqueness of our the female body. So, thank you very much.
Thank you all very much for having me here today. I'll begin by stating that for most of us, when we think about healthcare in our modern Western context, I think we're often discussing those people and those systems related to the skilled, trained, and board-certified practice of professional healing, right? So we're talking about medical doctors, nurses, physical therapists, and the like. So I am delighted to be a part of this panel because I believe the Drs. Heyne, Dr. Flanigan are shining examples of what I think we should claim as an authentic Christian perspective on professional healthcare. That is taking up the call of whole person healing and ministry, participating in a formal way in the healing ministry of Christ. Now, this places a certain burden on our physicians to not just be adept at understanding and healing the biophysiological processes of the human person, they must also be pastoral, right? Understanding the deeply spiritual components of healing as well. But from my perspective, I am not someone who is a formally recognized healthcare professional. I have been a natural family planning instructor for over a decade. We don't have an MPI, so can't bill insurance. I'm not a formally trained healthcare professional, okay? But I am here to encourage us, from my perspective, as to how the opposite must also be true, namely that an authentic vision of Christian healthcare means that all of those whose work revolves around spiritual care, so I'm talking about people like theologians, clergy, spiritual directors, pastoral ministers, we should all be a bit more biophysiological, okay? And for this, I am going to take JP2 as my guide. This is a great segue here, okay? In Mulieris Dignitatem, JP2 wrote these fascinating lines here. The woman's motherhood in the period between the baby's conception and birth is a biophysiological and psychological process which is better understood in our days than in the past. It is the subject of many detailed studies. What the different branches of science have to say on this subject is important and useful, provided that it is not limited to an exclusively biophysiological interpretation of women and of motherhood. Such a restricted picture would go hand in hand with a materialistic concept of the human being and of the world. In such a case, what is truly essential would unfortunately be lost. We could spend a lot of time talking about that paragraph. From a physician's point of view, this is JP2's call to make sure that we do not restrict our understanding of the human person to mere physicalism, or what he calls a materialistic concept, reducing the person to mere biological processes. However, note the interesting thing, he touches on something very important. Woman and her dignity are not reducible to biological function. Dignity cannot be lost as we lose our biological function, okay? Yet JP2 is also taking it as a given that our church's theological exposition on motherhood can be enriched as we better understand the biophysiological and the psychological processes of conception, pregnancy, and birth. Woman is certainly more than biology, and yet she is not woman without her distinctly female biology. The corollary can be said of men, of course, right? So what I worry about is that in our pastoral ministry in the church, we are sometimes so quick to try to heal the spiritual wounds of men and women that we miss or we downplay or even outright disparage the physical aspects of their woundedness. Now, I'm speaking from the perspective of somebody who works in natural family planning and psychoeducation ministry. This is a place in the church where I think it's very natural and actually required for instructors to balance biology and pastoral ministry in a very delicate way. But I hope that you can kind of ruminate as I'm speaking about how my comments can be applied to other areas of ministry in the church as well. So the first question I will pose is, what if the reason we have almost wholesale rejection of the church's teaching against contraception isn't because the majority of Catholics have seriously thought about the moral issues, they've formed their consciences, and they've determined that they must dissent, right? What if the reason is precisely because we have not been forthright in our pastoral ministry about laying the biological foundations with our young people for the church's teaching on marriage, sexual intimacy, family planning, and that crucial virtue of chastity, which requires an understanding of oneself as a sexed person meant to be in healthy relationships with other sexed persons. And in our efforts to show that the church stands contra the culture of death, in an attempt to properly honor and reverence motherhood, we have often reduced the image of woman as a sort of elevated symbol of pious fecundity, right? Without doing any serious theological work, to think about the fact is, she is the less fertile sex. Women only produce 1, possibly 2 viable gametes every 30 days or so, compared to a man who produces, on average, 1,500 sperm per second. And eventually, women halt with gamete maturation altogether in menopause, whereas men just keep on going, right? So I would love to sit here and just share fun fertility facts all day. For the sake of not being weird, I'm going to make my point. There are many very real, very pressing reasons why it is imperative for the church to become more biological in her pastoral ministry today. While society weaves the narrative that our sexed bodies are malleable, interchangeable, and nothing more than an external arrangement of parts that just kind of look a certain way, the church must absolutely promote a vision of the whole human person, body and soul, understood as something given by our Creator as a visible sign of himself, imaged with equal dignity and meaningful difference through male and female. And to be clear, I do not think the church needs to be more specific about the morality of specific discrete actions taken by the body. No, we don't need manuals on sexual ethics, please and thank you. What I am advocating for is a church which regains its sense of the sacramentality of the human person. You're going to hear JP2 all throughout this, right? How each of our bodies is an active sign of an invisible reality in the world. Now, this can be done in many ways, but I'd like us to consider the words of somebody Dr. Heyne introduced us to earlier, Blessed Nicholas Steno, a 17th century bishop from Copenhagen. He made significant contributions to the fields of geology, paleontology, crystallography, and anatomy. In short, he was a busy guy. But he said, "This is the true purpose of anatomy, to lead the audience by the wonderful artwork of the human body to the dignity of the soul, and by the admirable structure of both to the knowledge and love of God." So I'd like to take this concept, namely that learning about human anatomy and the way our bodies work can be a first and very important step towards a true relationship with God. And as an example of one ministry area where this could be applied, I will share with you a model that I have developed through my work at Thistle, which reimagines the way our church can provide lifelong education and support in issues pertaining to these bodily functions of menstrual cycles, fertility, and natural family planning. And it all really began with me feeling like a very big failure, okay? So after becoming an NFP instructor, I had the pleasure of teaching a woman who was a nurse. She was eagerly anticipating her wedding because of a restrictive schedule and the timing. She and her fiance were already talking about trying to conceive right away, okay? So I was halfway through our first instructional session when all of a sudden she burst into tears. And I'm sitting here going, I am officially the worst NFP instructor in the whole world. Like, what did I say? What did I do? And so I took a step back and I said, "Oh, I'm so sorry. Is there something wrong? Do you need me to leave? Do you need a minute?" And between tears, she sort of waved me off and she said, No, Christina, it's okay. She said, "I am just so angry right now." She said, "I am a nurse. My job is to know about how our bodies work. And I went through all that intensive training in nursing school. And this is the first time sitting here in this parish hall basement with you that I actually understand my menstrual cycle." She said, "I feel betrayed by my profession." And then I started paying attention as one by one, all of the other women and couples that I worked with said they were frustrated that they had never learned this before either. I had felt that way too when I first learned about natural family planning, but it sort of felt like maybe that was a gap in my own personal education. Now I was seeing that my experience was not unique, and I began thinking something is wrong with our systems. Because the problem wasn't just that proximate marriage prep was the first time people were learning about that information. That's a big problem, right? But also that proximate marriage prep is actually a really bad time to be learning this information. Couples are stressed with wedding planning, which means they have limited time in which they can just catch up on all this body literacy they should have learned 10 years ago, right? But stress can also have major negative impacts on a woman's menstrual cycle. So she may begin charting right when her cycles are at the craziest. I've seen delayed ovulation, short luteal phases, and ovulatory bleeding. Her first experience of trying to learn how to read her body is frustrated because her body is doing things it has not done before because she's freaking out, okay? And then the couples get really nervous that this isn't gonna work and it's just gonna be too confusing and we're just gonna have to abstain for our entire marriage, right? Do you see the issues here? Our pastoral model identified marriage prep as a time to learn about NFP with zero regard for the biophysiological and psychological difficulties that can present itself in the act of charting in this proximate time. Now, don't get me wrong. I am incredibly glad that the church has not only preserved but has stewarded the research in modern methods of fertility awareness and natural family planning, while the rest of the world was just largely content to never think twice about women's bodies, right? But now that we know so much about the menstrual cycle as a vital sign of women's health, I think we have the opportunity to think about how our pastoral models can shift with this knowledge. And just to be clear, a parish ministry or a Catholic school model does not require a parish staff person to do this. It can be as simple as getting the educational materials into the hands of parents, or having easy ways to connect your parishioners with diocesan resources, okay? Subsidiarity does require, though, that we make an effort at our parish and our first local level. So, the model that we've come up with at Thistle starts here. At around age 9 to 11, we begin with the foundational stage of cycle awareness for girls. The core message of this learning stage resonates with JP2's theology of the body. My body speaks a language, and I can learn to read it. Cycle prep provides an introduction to the menstrual cycle in a positive, non-shaming way. Girls and their parents learn about ovulation, menstruation, and how the cycle works using memorable storytelling and visuals appropriate for their age level. They gain awareness for how to care for themselves as their bodies go through these changes, and they receive a commission to extend that care to others. For families that want an explicit theology of the body tie-in, we have a short video series that talks about the language of the body, how our bodies are created to give and show love and truth. Now, I am willing to bet that that is a very different sort of educational model than most of us girls received when we were growing up. Now, lest you think I'm overstepping and creating something totally alien to the guidance of the church, we can go back to 1995 to a document called The Truth and Meaning of Human Sexuality, issued by the Pontifical Council for the Family. It is directed primarily towards the formation of children in the virtue of chastity, which I've already emphasized, at the service of vocation. In the puberty stage, the document says that we should be inviting children into ongoing conversations about explaining the process of puberty in the proper context of reproduction, marriage, and family, and we should begin with the biological changes that they need to navigate, and then gradually extend to conversations about sex. And you're going to note this structure in all of our offerings, that we root everything we say in an accurate presentation of anatomy and physiology, but then we invite girls to understand how that biological underpinning enriches our understanding of ourselves, our own dignity and our uniqueness, and the sorts of relationships that we should cultivate with others. So the next stage is the application stage of cycle charting, once girls have hit menarche, their first period. The core message during this stage is, I can listen to my body and respond with wisdom. So girls are taught about why teen cycles are different as their HPO axis matures. And if you didn't learn that, we could teach you, right? Why ovulation is so vital to our health, especially in these years of growth. They learn to identify normal and healthy cycle patterns specifically for teens because those parameters are different for teens than for grown women. We help them build an understanding of this development of their bodies to be able to make wise choices about health, exercise, diet, and even mental health in light of this cyclical knowledge. If they choose to chart, they're charting for ovulation as a healthy biomarker, not for fertility as they would do with family planning. As they mature even further, we follow the guidance of the Pontifical Council for the Family to expand conversations of body literacy to those explicit church teachings on marriage, sex, and family planning. But again, we're making sure that we're explaining why these teachings are in harmony with the biological designs of our bodies, and not just handing them a set of rules and restrictions. In this way, we are helping them progress towards chastity, the proper integration of our sexual self. And all of this leads to the next stage of learning for young adult women, which we call the integration stage. This is for women aged 18 and up who have matured a little more. They're capable of combining practical knowledge of cycles with deeper reflection on what this can tell me about my identity as a daughter of God, how this may be related to questions of vocation, including whether or not my menstrual cycles show any potential signs of fertility issues. Now, more so than in the earlier stages, I see a real hunger for the church in this stage today. Young women and even young men are seeking this information from the church. Our young people are hungry for a vision of the human person, which tells them that the core functions of our male and female bodies are not optional. They are not things we can ignore or just turn off and turn on. This is the lie of the birth control and IVF industries, as well as the corollary movements towards transgender ideologies. And here I want to mention again how important it is that we root any of our pastoral responses in biology. Because unfortunately, I'm starting to see a shift, especially in young men, who are convinced that all of the things that society says about pregnancy are a lie, okay? Including the idea that pregnancy can come with life-threatening complications. I had one young man raise his hand during a presentation that I was doing recently in Boston, and he's like, So there's these people who say that we need to have birth control and family planning and stuff because women could die. How do you respond to that? And so I thought he was asking, well, how do you defend the church's teaching in those cases, right? So I addressed that. I shared about some serious issues that my clients had faced, the heroic things that I have seen couples do. And he interrupted me and he was like, wait. So it's like, real? He was asking me how to respond to what he thought was a lie, that pregnancy could ever be difficult or life-threatening. So I affirmed that, yes, it can be very hard, and he looked stunned, along with like 6 other guys sitting with him, right? Can you imagine if these young men became priests? What sort of spiritual direction or pastoral counseling would they have given women or couples thinking that there were no health risks ever associated with pregnancy, and there were never any serious reasons to postpone a pregnancy? Or how women are treated. I notice when their parish priest believes that they cannot have a D&C procedure for a missed or incomplete miscarriage, telling her it's the same thing as having an abortion. So we really need to make sure that all of our pastoral efforts to articulate an unapologetic pro-life stance without running roughshod over the totally tough situations that are sometimes rooted in our biological systems. Those are real. A pastoral response which does not acknowledge suffering or hardship is not the response of Christ. And it should not be the response of his beloved bride. Men and women need to know about the way that endometriosis destroys a woman's fertility and can cause incredible levels of pain and suffering. They need to know about hyperemesis gravidarum, which can send women to the ER with severe malnutrition and dehydration, or the trauma of postpartum depression, infertility, repeat miscarriage, and so much more of the suffering that largely goes hidden and undiscussed in our pews because women and couples at various times have been taught that this particular type of suffering is shameful or even sinful. Don't get me started on the damage that is done when we tell couples that they only have to abstain only 6 days a cycle when using NFP. Or that if they just read theology of the body and understood the spousal meaning of the body, that they will always have mind-blowing sex with their spouse. I am not joking. Okay? I will leave my list of grievances there so I can get on to the 4th stage, which we call the advanced application stage, using information about menstrual cycles and charting for the purpose of family planning, whether to postpone pregnancy or try to conceive. Of all of the stages that I've covered, this is the only one that I do see parishes providing on a sort of regular basis, but even then it's pretty spotty. And we are making a huge mistake if we limit access to natural family planning instruction to marriage prep. A lot of times parishes, if they offer this education at all, limit it to engaged couples. And they forget that fertility is a moving target as couples go through their reproductive lives. We need to make this information available to couples through any sort of transition, like postpartum, perimenopause, navigating a new medical diagnosis. And we would intuitively know that if we seriously thought about the normal biological differences between a woman's cycle at age 25 versus age 45. Or the whole body effects of something like chemo. Individual NFP instructors know this, right? But what a huge difference it might make if our cancer support prayer group or the new baby meal trainings also included some basic information on how to connect with an NFP support person. Could be that simple. Now this narrowly demonstrates a way in which just one aspect of our biology could be integrated into parish ministry and pastoral models more intentionally. But I hope that by extension we can also consider other areas in which our bodies and our physical health could be brought into Catholic conversations a little more regularly. Our religion does not allow us to be merely physical in our care of the human person. We've seen that. And yet, our faith, with this emphasis on the incarnation, death, and resurrection of God himself, does not allow us to not be physical. Our entire sacramental system would be completely incomprehensible without that belief. So it is my sincere prayer that our church pays close attention to the signs of the times and encourages thoughtful reflection on new scientific information in light of the gospel, never reducing the person to mere biology, but never forgetting that anatomy can be the start of a new ascent to our love for God. I believe this is crucial for a Catholic approach to healthcare, which includes the skilled whole person care of doctors and nurses, yes, but also the whole person care of those in pastoral ministry as well. Thank you very much.
Wow, Christina and Nancy, thank you guys so much. I'm going to start out with just a very little practical question. We talked before about witness, how when you're in the medical profession, how witness to our faith, to Christ, is so critical. Give us some advice, both of you, on how to start the conversation on fertility awareness-based methods, whether it's with friends, with family, in your broader networks. I mean, you know, hey, give us a hand.
I think we're on here.
Yep.
Yeah, I mean, so from where I'm sitting, right, I would love us to just be more comfortable talking about these things in the context of church groups. I mean, I remember being a part of a women's Bible study many years ago, and we talk about babies, and we talk about all of these things going on in our lives, and, you know, a couple of us were charting at the time, and just felt comfortable talking about that in front of the other group. None of the other women in the group were charting. Now, what is this thing? A couple of the women were from Latin America, and they had been taught that the church's stance was only against hormonal contraceptives. They didn't believe that the church had a problem with any barrier methods or with IUDs or things like that, the non-hormonal. And so they were just completely misinformed about what the church taught and thought that they were following church teaching. And so I think the first thing is to just realize that this can be integrated into our conversations and to not shy away from these topics. Don't shy away from talking about miscarriage experience or infertility or endometriosis or these experiences that are very physical and affect our spiritual lives. I think if we gave ourselves permission to speak about these things in times when they would naturally come up, how easy this could be, because then you can easily share with other people who get curious. They go, wait, what are you talking about? What? People have a curiosity about it. They want to learn.
Completely agree. People are very interested and curious. I think we're in an interesting era of being pro-natural. Even in the secular world, there's a big push for, you know, going organic or, you know, being aware of environmental toxins and things like that. And so really using that, I think, has been really helpful to introduce the idea of like, oh yeah, like we can do things in a more natural way, and what does that look like? How can we make observations in our body? And you know, I've had friends who are perhaps not practicing Catholic, and you know, they've come to me with certain reproductive, hormonal related concerns, and you know, that opens up the topic of, well, maybe we can do things differently. Maybe you don't have to be on birth control, and we can explore other options. So just being more open to those conversations.
So two movements that are going on, which you just alluded to and were mentioned here. One is the incredible awareness of cancer risks and how the medical profession really has just decided not to talk a lot about increases in different cancers related to OCPs and that concern. The second is the really explosion of technologies that keep us in touch with our body. You guys probably are familiar with many people who wear the Oura ring. I don't have any stock in it, so I'm not pushing it. But you can look around, you see a lot of folks wearing these large bands and rings. They're quite extraordinary. And they measure, for example, your basal temperature in a very, very accurate way with, really high-level quality of readings, and feed it back to you within, really easy to understand apps to measure it. And suddenly, you're in touch with changes in your body, which you really were not in touch with. And many of those changes relate to our hormonal changes, the fifth vital sign of ovulation, menstruation, or early changes which occur in your temperature during conception. So the first sign of pregnancy is, ooh, look, my temperature changed. Quite really interesting. So that's also happened, and that often happens in folks that it's not faith-based, they're just really very body-oriented. So have you all seen how this has played out?
Yeah, how it's, the use of technology, like I said, I think we're very interesting times with the use of technology. They're more, even within NFP, things have changed, right, Christina? Where, the ease of, before it used to be even for temperature measurements with charting, it used to be that a woman was expected to use a thermometer to check her morning first, her temperature when she first woke up in the morning. And now there are these more intricate temperature monitors, or you can wear 24/7, and it provides a more detailed graph of how your temperature varies throughout the day. So, using all those tools for the purpose of really learning more about our bodies, and then the question is, how much is too much? I think at a certain point it can become a little overwhelming and having too much information, but certainly some information is helpful.
Yeah, I think from the standpoint of a natural family planning instructor, this is an exciting thing, but it's also a little bit of a frustrating thing. So there's tons of technology that's available. The problem is tech companies are so quick to get things out there, to get something into your hands, that there is not seminal research done on the efficacy of charting something like your basal body temperature with a distal temperature at the finger or something like that. We have minimal research going on with axillary temperatures, but the gold standard with research with basal body temperature was actually with vaginal temping, which was studied with oral temping back in the 70s. And so we do have kind of an explosion of information that's available at our fingertips. Not all of it is as high quality as we would want it to be and as accurate as we would want it to be for something like family planning. And so, there's this delicate balance between saying, there's this great new technology, it hasn't been studied yet, we gotta do the work, and it does in some cases then look like the church is playing this kind of tug of war with we don't want to embrace the new technology. Well, actually, we want to make sure that this new technology delivers, right? And so I've had some interesting conversations with clients who they want to try these new devices, and I have to say, well, actually, you know what, we can't do the temperature for the basal body temperature shift with this distal temperature because we don't know if it works yet, and they get all frustrated. And then there's the other people that believe that the Catholic Church is so against technology that they're not allowed to use a hormone monitor because that would not be natural. So we have a lot of education and a lot of sort of things we have to kind of balance there as new technologies come on the market.
Questions for everybody?
Thank you. Thank all of you. I'm a retired physician myself. And so one of the questions I have is, and it actually goes back to your initial introduction. You were at Brown, you're at Harvard, pinnacles of the healthcare system, and also your husband mentioned something about the epicenter of secular medicine. And you mentioned that you got a call about you, right? About doing something. Are things not as bad as I think? I mean, do these institutions countenance this type of therapy? Particularly since 2020. I'm, as a retired physician, I actually read the American Medical Association statement on health equity. It's not just the good things. It's about power, oppression, white supremacy, the language we can use, it's gender. I don't see how you can practice in this environment. And they're doing it in the medical schools too now. I mean, the American Medical Association of American Medical Colleges put out a similar statement on, health equity, and it's really the critical social justice theory that's embedded in there. It's more political than anything else. So how do you get away with this stuff in these institutions?
That's a really good question. Well, it's challenging. It really is. I won't downplay that. It requires a lot of prudence, knowing what to say and how to say it. I'm sure Deacon Dr. Tim can agree with that. And just focusing on the positives, I think, is helpful. So what does our faith have to offer? And just the social justice theory, the compassion that comes in our faith, and just seeing our patients, right, as Jesus, right? And so seeing what us as practicing Catholics, both myself and Tommy, bring to the table, there's such a push for diversity, that we are diverse. We're bringing, we're bringing diversity to our current secular medicine. It's just being very thoughtful and being respectful. And sometimes it requires perhaps not saying things, even though we would love to say things, speak up. But it may not be the right time, the right place to speak, perhaps publicly. Perhaps it needs to be a private conversation. We've had very interesting conversations in private with colleagues. So it's that sort of ongoing, it's an ongoing challenge, yeah. But it is possible. I will say within, especially in the Northeast, it can be more challenging within certain areas of medicine. So both my husband and I practice medicine within the hospital setting, where there are some ethical dilemmas, but perhaps not as much as the primary care setting, which has its own challenges. But it really depends on the field of medicine at this point. But still, it requires a lot of prudence and prayer and God's grace to get us through certain scenarios.
Yeah, two brief thoughts. One is, the goal isn't really to argue with anybody in the medical world. The goal is just say, gosh, I see things differently, or I view things differently. Not to convince them, just to witness that there's a different view. So you got to get out of the argument phase. Argument is not, you're not going to win anybody over by argument, but just making them realize a different view in that regard. The second is, you'll see people get up and publicly disparage you and your faith and things you believe in. And you really can't sit there and somebody else giving a lecture, and you can't get up and say, oh yeah, that doesn't work. So you got to suck it up and offer it up to the Lord. I mean, part of our faith is, Jesus said we are going to be persecuted. And the third is that the medical professionals today that go through the system, that hold on to their faith, are much better able to live this sign of contradiction that John Paul II talked about. They're better at it than I am. Because when I went through it, it was more comfortable. Our medical students today that are practicing Catholic and love our faith, boy, it's really extraordinary. And I really take my hat off to them. So the Holy Spirit is very much at work, even at Brown, at Harvard, at Columbia. The Holy Spirit, you never underestimate the Holy Spirit.
Thank you. 2 quick points, and then I have a question. Or maybe I'll just do the question. So I taught for 5 years at St. Charles Borromeo Seminary, and you mentioned that priests have a lot of misconceptions, and you said, I'm so surprised I'm talking about the menstrual cycle at a monastery. But to my great surprise, when I got there, I was asked to teach in the theology at a course called Catholic Teachings on Marriage and the Family, and they required that it be co-taught with a Creighton model-trained nurse practitioner. So on the first day, I told the guys and their clerics, today you're going to learn how to chart, guys. And it was just them. And she did the first day with a little book, with a little blue and yellow book. Kyle Bider came, who's a nephrosurgeon, and he actually showed us videos of him zapping endometriosis and ovarian resections. And it really woke the guys up. And then we tried to have them do homilies that could get... So I guess what I'm asking is, have you ever approached seminaries? Because I think the seminarians need to feel it and see it if they're going to help in the parishes.
Yes. I give an annual talk to the seminarians at St. John's Seminary in Boston. And we talk about pastoral issues related to natural family planning. We talk about how charting works. We talk about all of these different reproductive disorders. And then we talk about the discernment that couples go through. So I would love to be in more seminaries. I know that there's a handful of seminaries around the country that do have similar programming, but I'd love to do more.
I think we have time for one more question.
Thank you so much for this great presentation. So as a Dominican and as a teacher, I have a great passion for the education portion of this. And so this might be specifically to you, Christina, and Thistle, but I just wanted to say I've been incredibly heartened over the last few years by a rise in programs put up by the laity specifically to teach theology of the body at younger ages, or the language of the body as gift, the language of who we are as a human person. And so a number of our schools have adopted the Rhode Woods curriculum, which helps to teach, even from kindergarten, that language. They start to understand who they are. And while that is absolutely wonderful, I've often thought this would even have more about a kick or a punch if we could get it into the hands of the families and teach their parents. So it's a more organic conversation, not just our teachers teach us this at school, but that these very delicate and sensitive topics are also opened up within the family sphere. And so I'm very excited about this, especially to pass on to many that I think would benefit from it. So I'm wondering specifically your vision for the best mode or place for these materials, to be given out. Is this ideal or best in a school club optional setting after school? Is it best for parents at home? Is it best for like an all-girls club? Is it best for like a youth minister, like someone that they really respect? Where does it seem to have the best effect in being taught and then continued on?
Yeah, absolutely. Thank you for that question. So I have lost a lot of business because I insist that with my cycle prep program, the parents are there with the girls. Because I have seen how important it is to have a shared learning experience, because the moms don't know this either about their own bodies, and they are completely at a loss for how to explain this to their daughters. And so the greatest gift that we can give these girls is to educate their parents along with them. And so for cycle prep itself, it's been done a number of different ways. Primarily is done as a self-paced video course at home, but there are a group of options where you can host something after school or with a club, and as an opt-in where the parents come with the daughters. And that is absolutely crucial to the learning model itself. So I'm happy to chat more about any of those logistics, but yes, so a lot of my materials are designed to be done with the family, with the domestic unit as the primary place of education. And so we, as schools, as parishes, are the subsidiary organizations that are helping to facilitate that primary education through the home.
Can I mention just observation? My wife and I use natural family planning in an attempt to get pregnant, and it's very effective for that. It came, we use a special thermometer, which is what you mentioned, that don't, unfortunately, or unfortunately, don't use anymore. And we talked about mucus and temperatures and everything like that on a daily basis as we attempted to get pregnant and whatnot. But the thermometer came with an insert that was very fine print and probably 4 or 5 pages long that really gave you like 99% of what you need to know and what you probably teach in your natural family planning. So if nobody's actually read any of that stuff, go find one of those thermometers, get the little insert and read it, and it'll be mind-blowing, but it's something that everyone should know.
Great. I think we've got some housekeeping items right now. Daryl's going to give us some thoughts here. But I really want to thank Christina and Nancy. Thank you guys. That was great. And a really great
Okay, so just a few program notes. Listen carefully. Our breakout discussion session, our first one begins at 11:15. Please note in the programs which rooms for which selections in the Summer Symposium reader. Rooms 201, 202, and 203 upstairs down this hallway. So following the breakout discussions at 12 p.m., you're invited to midday prayer in the Abbey Church, which begins promptly at 12:15. Lunch is available starting at 12:30 in this room, and lunch will be available running up until our third panel begins, also in this room, at 1:45. So thank you. Yes.
Very good.
started at our parish. I'll
Yeah, absolutely, because most of our things are just, the idea is,
Christina, I wasn't really looking what Sister Christine mentioned that we So, and I'm very interested in teen men and teen femmes. And boy, is it hard for somebody who's not very involved to navigate it all, you know what I mean?
yeah.
So, have you seen teen men and teen femmes curriculum?
Yeah, I have.
And I don't mind hearing criticism or whatever. I mean, I'd love to hear your thoughts on it.
It's very, what I like about it is it's plug and play, right?
Yep.
So you just get it and
Yep.
it's all very naturalized, which
It's a really interesting line. If you absolutely right, because WHO, a lot of the so the response to that, with reproductive education is not the knowledge. And it's not things that can kind of language when you teach it, and this would have happened 20 years ago. Tell you
yes.
It's awesome. I've never been there. I was here with it.
It was so worth it.
Yeah, what is it?
Great.